Thank you, Sonia, for the introduction, and thank you for the organizers who organizing this. And then also want to thank Andre for the invitation. So I'm Jingjie, assistant professor with NC State. I'm primarily based with Department of Mechanical and Aerospace Engineering. So as a mechanical engineer by training, I do a lot of biomaterials. So there will be I guess there will be more of the materials in my talk than biological physics, but hopefully I can convince you how we can use mechanics and materials for something that's is clinically relevant. And in particular, the topic for today would be for embolization. If I were in an in-person talk, I would ask people to say, hey, could you raise your hands if you heard about this word? And to be honest, 4 years ago, that was my first time who heard about this word, but since then I've become very, very interested in it. So maybe I can give you an example. So we all know stents. Stents is trying to open a blood vessel, and embolization is doing exactly the opposite, which is trying to block a blood vessel. Now, the question usually comes is like, why would we ever want it to block some vasculature? So it is a very it's really the state of art nowadays as compared to open surgery, as it's a minimal invasive procedure to intentionally and to treat diseased or injured vasculature for a variety of diseases, such as hemorrhage, aneurysm, vascular malformation, and tumor, which can be either cancerous or benign. And the way this thing works is really amazing. The way I think about it is like, here are two examples. One is for fibroids, which are one of the common benign tumors that happens in female. And traditionally, when one had very large fibroids that become unmanageable, then the way is it's pretty disastrous by removing the entire uterus. But with embolization, if you think about it, it's a benign tumor. The way the tumor grows is that if they have these, we also call it hypervascular tumor, meaning that they have overexpressed these feeding arteries. That's where the blood, nutrition, and oxygen go into this lesion that makes it to grow. So with embolization, what people do is one take a very long thin tube that we call a catheter and maneuver the tip of the catheter to the vicinity of the feeding arteries of the tumor and deliver what we call, maybe I can put out a pointer or something. Yeah, here, let's try that. And we can put the tip of the catheter to the vicinity of the tumor and deliver what we call embolic agents. In this case, are microspheres, which are under of hundreds of micrometers or a little bit less, which are comparable to these feeding arteries. So as you can imagine, the goal of these little microspheres is to mechanically block these feeding arteries. And therefore, the tumor, where the tumor is getting all those things to let it grow would be cut. So the blood supply would be cut off, and then the tumor will gradually shrink, and the patient will go back to normal. So there's no need in the where the patient being where the patients are being suitable for this technique will be able to return to a normal life in a very minimum invasive way, because there's no need to do the open surgery. And another example is for aneurysm, which are balloon-like structures that could happen anywhere in the blood vessel. And one of perhaps the most dangerous is in one's brain, because it can really lead to stroke. And again, traditionally, the way to treat aneurysm is by open surgery, by putting a clip at the tip of this neck to exclude this sac away from the parent vessel, because this sac over here is very prone to rupturing. That's where the intracranial hemorrhage occurs. Now, again, with minimum invasive surgery, which is embolization, what people do is they can puncture a hole at the carotid artery around the neck, maneuver this catheter to the vicinity of the aneurysm, and deploy coils, which is another type of embolic agent, the thing coming out of the catheter. And the coil would conform to the shape of this sac and stop the turbulence of the blood going in here and promote clotting. So therefore, it will exclude this aneurysm again away from this parent vessel, but without need with the open surgery. So in short, the embolization is offering much fewer complications with better outcomes and lower cost. That is becoming a mainstay of vascular intervention nowadays. So here's the thing, before getting to the main science, I want to explain how do we know where to put the tip and where do we deploy this agent to know where to exactly target. And this has to do with what we call angiography. In other ways, it's a real-time X-ray. So there are a few essential things. One is contrast agent, which is usually iodinated so that it can be shown on the X-ray. And number two is the catheter. So again, our talk today is all about catheter. Again, it's a very long thin tube rather than the short needles, because this is the thing that can really go into the vasculature, essentially like a highway map that's coming from the head all the way to the toe inside of the human body. Now, what the interventional radiology who are specialized in this, what they do is, for instance, this patient is undergoing this procedure, and they will puncture a small punch. For instance, at a carotid artery or femoral artery, and depending on where that is, and insert this catheter through there. Because the catheter is also intrinsically radiopaque, that is why it can be seen under X-ray. So if you know this, a real-time X-ray is called fluoroscopy. It's also called a C-arm because it has a shape of C. And the X-ray is really coming from these two nodes that can move up and down, left and right, either robotically or by human. So that the goal is by injecting this iohexol, which is a contrast agent, through this catheter, it will really light up this vasculature so that we would be able to see whether this to be targeted blood vessels are patent or not. Since this case is patent, that is why the iohexol can get into these branches and showing the structure under the X-ray. And another thing I also want to mention, this is not a movie, but it's a real-time X-ray. So basically, they can really see how they look like. The physician can really see how they look like on the screen and determines when to deliver. So again, we're talking about the things coming out of the catheter. And again, we want to do something clinically relevant. So currently on the market, I've already shown two things. One is the microspheres, for instance, on the previous slides, on the fibroids, another are the coils to the aneurysm. So the big categories that embolic agents nowadays are either solids or the liquids, such as the glue. But they're all associated with some advantages and disadvantages, one of which is being the solids, for instance, they cannot occlude the very soft blood vasculature 100%. That will cause recanalization, meaning that the already occluded blood vessel will be subjected to reopening, so that the patient have to come back and redo and re-undergoing this procedure. Again, so you can see this is under X-ray, and this additional exposure is also really unfavorable. Additionally, the liquid, for instance, people now use glue or some onyx, but they are all really organic solvents, and some of them even include DMSO. As you can imagine, if they're inside of the body, it's becoming very toxic, especially for the heart. Regardless of these disadvantages, they're all using successfully, but we are trying to make it a little bit better. So the way we're considering is they are solids, they are liquids. Why couldn't we do something in between, which is inherently have both the advantage of the liquid that can go into the vasculature to occlude these vessels 100%, for a successful treatment, but also have the capability of forming like a solid that will stay inside to prevent migration, because distal migration will also be very dangerous of leading to the stroke, can be either in the brain or the lung. So here we introduce for the first time, actually this is my postdoc group, the shear thickening gel embolic agent, but for transcatheter delivery. We actually have been working on this for a lot. There's really different type of embolic agents. So here I want to introduce one of the very first ones. It's coming from a bioactive material. And if you know, this is extracellular matrices, and it's really where the cell's original home is, because essentially we want to heal this diseased vasculature. And the current liquid and solid, they do not carry therapeutic effect for the most of the time. So with acknowledging all these current limitations, we want to bring this bioactivity to promote tissue regeneration, in addition to being shear thinning, because the shear thinning property is really allows this transition from liquid to solid upon the injection of the force. And one thing we noticed is that we extracted this ECM from the left ventricle of the pig heart because it's there's like current study showing it's pretty regenerative. That's why we picked that up. But another thing is it's really soft. By itself. So we wanted to increase the mechanical strength that we're introducing another artificial platelets, which is like nanoclay, have anisotropic charges on the surface and on the edge that would interact with this protein to form an electrostatic physical network that would deform and reform under mechanical force. And in the end, we tested in the animal models, which I will talk about in a little bit. So just quickly go over this. The decellularization is really trying to remove all these cells to prevent this immunoresponses as we're introducing from one species to another species. And in the end, we're just leaving with this scaffold-like structure, but we're not generating these with artificial structure. We extract it from the real animals to preserve the most of it. And we did staining to reconfirm that all the blue, which representing the nuclei, are gone, as well as some other assays to really confirm the successful decellularization. But these proteins, such as collagen, fibronectin, laminin, some for adhesion and for regenerative purposes, are still remaining. We also solubilize this sort of like very hard structures into soluble structure using pepsin because we wanted to make this malleable gel that can be injectable through this lung catheter. And we confirm that it is all shear thinning, although from rheology you can see the maximum storage modulus, which is the indication of how strong this gel is only on the order of 200 pascals, which is too soft to withstand biological or physiological pressure. So that is why we introduced artificial nanoplatelets that has a negative charge on their faces and positive charges on their edges, and to interact with extracellular matrix. That is a very complicated charged protein. So under shear and unshear, meaning that injection and cease of injection, this material can extrude like can travel through the catheter like a liquid, so it's easy to inject. But once the injection was being removed, it will resolidify into a sort of like solid that serve our purpose to stay within the vasculature and do its job by blocking the vessel. And we make different versions. As you can imagine, if we just tune these different compositions, will be achieve multiple formulations as a family of these materials. And we confirm that they are all intrinsic shear thinning that facilitate transcatheter injection. Whereas when we're having more of the extracellular matrices involved, this G prime, again, which is a storage modulus, increased from original the material itself was 200, but then with the for the ECM, but then with the introduction of the nanoclay, we were able to tune all the way from a little bit less than 1,000 all the way to almost 7,500 pascal. So the storage modulus, in other ways, the mechanical stability got increased significantly. So that's the yield stress that would allow the material to stay within the vasculature and withstand this blood pressure. Again, we also looked into how, because when the physicians are injecting the material, they may not inject just one time. They may inject, investigate, pause, and then do injection again. So that is where this recovery characterized by a cyclotropical test in the rheology showing the decrease of the viscosity and increased viscosity, that repeated injection do not compromise the mechanical stability significantly, again suggesting the practicality of our gel as an embolic agent. And one important thing is, I keep emphasizing this is a transcatheter material. You may already see a lot of injectable material, but this really in short needles that can solidify or depending on the interaction. Again, transcatheter, what we're talking about here is 150 centimeter long of the catheter that can go down to 1.8 French, which is sub-millimeter of the cross-sectional diameter. So you can imagine if you want to pass something through a very long tube, but with very short cross-section, the injection force increased significantly. But with this shear thinning property, we were able to get all the hand injection forces below the peak of, in this case, 30 newtons. And for a comfortable human injection range, that should be below 60 newtons, so that our material, again, is hand injectable. That is also in a controllable manner for the clinicians to use. We tested the cell viability, also showing this material is biocompatible and it was able to withstand pressure of up to 120 kilopascal. That's over 11 folds as compared to the healthy human physiological pressure. That's 120 millimeter of the mercury. That's around like 16-ish kilopascal. So one thing our current lab did is we wanted to really gauge to understand this material better in terms of can we really correlate it between the material's shear thinning property and injectability, because we're an experimental group and we can do a lot of material, but by doing a lot of experiments, we have to test both ends. However, there's a clear correlation between the material's shear thinning property, such as the viscosity, shear rate, with respect to the final injectability. So we want to do a prediction, and the way we do is quite straightforward by simplifying this catheter as with a long thin tube, and we consider it as an incompressible fluid, and this is a laminar flow because the injection rate is relatively low, so around 1 ml per minute. So in the end, we compared our experimental forces with predicted forces, not exactly 100% correlated, but they're all sort of around the line of the 1-to-1. And of course, there's limitations in the model because some of the material, they are not exactly 100% shear thinning. There will be some of like the slippery or and it's a complicated material. So using the power law that we're trying to correlate between the viscosity may not be that accurate. So those are the things we're also trying to improve in the future. But this would allow us to have a predictive platform that can help us to correlate with our material and the practical applications. So now we also tested it into a clinical relevant model. It's a pig model. So the way we do it is we try to use, in this case, a femoral artery just to see if the material would stay. And we put the catheter over here and inject the contrast agent, confirming the patency of the material. Then we inject our gel just at the tip of catheter because we just confirmed it. That is why this blood vessel is being blocked. But then on the static X-ray, since our material is intrinsic or really opaque, we can see it's actually blocking this vessel. So this is our material right here. And after 14 days, as you see, this vessel is like visually missing. It's still there. It's missing because it's still being blocked, suggesting this permanent embolization and stable embolization still occurs at day 14. It didn't migrate away. And if we look into the cross-section, there's some tissue remodeling that we characterize it. This is a cross-section of the blood vessel showing 30% materials being left. So what does the rest of the material go? From the histology, we see that it's actually being replaced by connective tissue. From the trichrome, this newly formed, very thin bluish violet color is actually the newly formed collagen. So our material is actually biodegradable as compared to most of the currently clinically used material that is not biodegradable. If you have a coil in their body, they cannot undergo MRI because the coil would remain there all the time.
Jingjie, just
yeah.
about 5 minutes left.
Yes.
Yeah.
Sure, thank you. Yep. So, but with our material, it can degrade and form as part of the body, but still remains this permanent embolization. And as you can see at day 14, these are still proliferating cells that there's further remodeling that is going, and then most of them going to be digested towards the with the longer period of the time. And we also try to look into another organ, which is the kidney, as you can see, to just try to look into how much like the penetration depth of this material. As you can see, the gel can penetrate around the main renal artery and these little branches. And what is interesting to see on this is kidneys and an organ. So that at day 14, because of the necrosis, meaning the lack of the blood, this kidney do not showing any a brightness under fluoroscopy because it's becoming necrotic. And if we look into the explanted tissue, the embolized kidney becoming smaller. Here's at day 14. If we actually have data, but it's not related to this work. After 30 days, it only becomes much smaller. So why is this important? It's because sometimes if one is under a kidney transplant, instead of removing one kidney directly, that may put the patient under hemorrhage. What the physician can do is to redirect all the blood into the healthy kidney and to starve this diseased kidney or to be transplanted so it can be safely removed. So embolization will not only be used for treatment, but can also be used as adjuvant therapy for the prevention. We looked into how much the gel would penetrate. It can go down to around like 150 micrometer. This is a blood vessel with gel in it. And we do not want the gel to go beyond the capillary because once it's going beyond the capillary, it's going to the vein and circulating inside of the body. That would also cause a stroke, which is pretty dangerous. And thinking around that line, we also did the whole body of the pig, and we didn't see apparent blockage or whatsoever, further confirming the in vivo safety of our material. So just to quickly summarize, in this work, we developed a bioactive nanocomposite hydrogel by tuning its mechanical properties and also biological activities, and we confirm its embolic efficacy in a porcine survival model. Because of the time, I will skip on this. I do want to acknowledge where the majority of the work is being performed at the Mayo Clinic, where I conducted my postdoc, and we're also this is also part of our ongoing work, where we're developing additional embolic agents as well as other vascular devices such as microspheres, which are currently supported by NIH and a bunch of other funding agencies. I also want to acknowledge my current collaborators, which allow us to do fun science and continue pursuing along this line, as well as my wonderful students who did most of the work. With that, I want to thank you for attention, and I'm happy to take questions.